So good morning again. My name is Vanessa Kuwijima. I'm one of the GI docs here with MU Health. So just to get a little bit of a feel of what our audience today, yes, thanks for coming, quite a few of you. So raise your hands if you're here from Colombia. I just want to have a few a little bit. Okay, so quite a few locals. Yeah, very good. And how many of you drove more than an hour to be here this morning? Okay, thank you. Thank you for the trip. So I'll just want to, my first disclaimer is, I don't know everything about GI, and I may not be able to answer all your questions, but certainly if there's something I don't know, towards the end I'll try to find out for you, okay? How many of you, so again, I'm a GI doc, and I love my job. I think that, the gut is really, truly amazing. And we also have, a great sense of humor in GI. We have to do what we do. So if you have a question, okay, about your bowels, please feel free to, raise your hand, interrupt me, feel free to ask, okay? Alrighty, so, no embarrassment here, okay? The gut is really important. So without further ado here. So I'm just gonna review a little bit the digestive tract, okay, the GI system. So the GI system is, of course, composed from this hollow tube from mouth to anus, okay? Your esophagus, stomach, small intestine, large intestines, and the other organs that are like accessory organs that make substances to aid in digestion, such as the pancreas, the liver, and the gallbladder, okay? So the goal is very simple, but it's also very complex, and certainly, even the most, simple invertebrate has a pretty good gut, because we have to, right? This is how we absorb nutrients, how we survive. It is very, very closely related to the nutrients we absorb from our environment, right? It is a very, very basic need of all living organisms. Any cardiologist here? Okay, no. So I can say, some people say the heart's number one, and I say the gut's number one. Okay, well, maybe number two. No, the brain maybe is number one. I'll give you that, yes. The brain is number one, the gut's number two. Okay, so the digestive system, very, very important, okay? And in order for us to be able to efficiently extract nutrients from the food we eat, the different parts of the GI tract have different functions, okay? For instance, the mouth. Chewing is super important, okay? Don't underestimate chewing, because you really have to take that food and break it into very small particles, right? To kind of help in digestion. Chewing is super important. And of course, saliva starts the digestion process in the mouth, okay? The esophagus, is a food pipe, right? It transfers food from the mouth to the stomach. And it might seem, oh, that's not important, it's just kind of pathway, but it's super important, because if you cannot transfer food from the mouth to the stomach, you cannot digest, right? And of course, I'm an esophageal motility disorder specialist, maybe I'm a little biased, but if you have trouble swallowing in the esophagus, it can become a big, big issue. And then, of course, the stomach. The stomach does a lot of the mechanical grinding of the food, right? And it's also a reservoir. If you're a cow, anybody here is a farmer? Anybody is a farmer? Alrighty. How many stomachs does a cow have? 4, that's right. So the cow has all these chambers, right? And they're really fancy. So delayed fermentation and all that. Well, we only have one. So our stomach does, a lot of stuff. It grinds the food. It's a reservoir for the food. It controls how much food goes into the small bowel. So it's quite a bit for one organ. And then the small intestines, they absorb, okay? They mix this food with different enzymes, and then they are absorbed, okay? So we have a very, very, very long gut, if you think about it. I've heard once somebody say, if you were to take every single, the villi, they're kind of like the projections in the gut. The gut looks like a little carpet, if you look at it endoscopically. I'll have a picture. So if you were to stretch that and tie it all together, folks have said it could go around the planet. That's, a lot of surface. Our gut has a lot of surface to absorb all those nutrients. And again, the large intestines, absorb water and also expel the leftover. So that's just a representation there, what the gut looks like. And oh yes, it does work, oh my gosh. Okay, so esophagus, stomach here, then small bowel starts here. And of course, this is not to scale. The small bowel would fill all this up. There's small bowel is very long, about 6 meters long. And then you have the colon here, and then the rectum. So that's what the gut looks like on the inside. You know, the stomach has all these folds that help grind up the food. The small bowel has, you cannot see much well in the picture, but it has all this little villi. It's like a little shaggy carpet. The colon is smoother, but absorbs a lot of water. And just have to put in here a little bit of a picture of colon cancer, because whether or not you have Parkinson's disease, colon cancer, number 3 source of cancer, you know, cause of cancer in the United States. So please get your screening done, okay? So this is a message for everyone. Okay. So the gut and the nervous system. So, you know, back in the day, I actually thought about becoming a neurologist. So that's maybe a surprise for you guys. But you know, neurology is also a wonderful discipline, very fascinating. And so true story, I came very close to becoming a neurologist. And I like to tell people that I do GI because the GI tract has the second most presence of neurons in the body outside of, right, the central nervous system. So in a way, you know, I'm a neurogastroenterologist, I suppose. So I fulfill that. But again, very, very complex, okay? So I'm not even going to go into the nitty-gritty details. But what I want to say is that our gut has its own enteric nervous system, okay? So it's nervous system of the gut. And it controls the functions of the GI tract. So just like the heart has its own kind of pacemaker, you know, your heart cannot stop. You know, it's kind of going, going, going. The gut is always going, 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 and you never stop to think about it, right? But the controls of digestion, the motility of the gut, it's 24/7. So it's really important that we have, you know, that system. And whenever we have an imbalance in that system, it will manifest with GI complaints. So it's important to know. And again, everything is connected, you know, your central nervous system, right? Your brain, the centers and the peripheral, you know, outside of the brain. And then with that, of course, it really links with the enteric nervous system. So, and just to get a little bit of a break here, I know there's a lot of information. The human brain cannot process more than a little bit at a time. So let's take a little bit of break. Question for you guys. How many of you have problems with the gut in general? Raise your hands. Okay, so you guys can see, very common, right? Very common. So again, in the end, if you have any specific questions, you know, please make sure to write them down or ask them as we go along, because this is really, really common. Now, link between the gut and Parkinson's disease. Again, you know, I love the gut, so I have to try to make associations, right? And again, I'm not even going to begin to you know, Parkinson's disease is very, very complex, and we don't quite fully understand how it's, you know, it starts, develops, you know, how that pathophysiology, you know, of Parkinson's. But we do know that there's abnormal protein deposition in certain areas, right, of the brain. And there are different kind of proteins, like back when I was in medical school, everybody talked about the tau protein, right? Everything was about tau. And now people also talk about alpha-synuclein as being another important protein, okay? Something that's very important, and you know, we're not exactly sure what this protein does. I mean, it has to do with signaling of those neurochemicals between neurons. But anyway, one thing that people have observed is this abnormal deposition of this protein that has been linked with Parkinson's disease. It's found first in the GI tract, and I find that fascinating, right? And not only found first in the GI tract, the concentration of this abnormal protein is found unevenly distributed in the GI tract, salivary glands being the most, and then mouth, and then esophagus, then stomach. So the more proximal, or the more closer to the mouth, the more deposition of this abnormal protein we see. When we look into, you know, people take biopsies and kind of staining for that in animal models and in humans. So it's very interesting because some people have speculated that there's a role in the gut in the development of Parkinson's disease. Again, this work is very, you know, only in the past few years, we don't really understand why. Is this just a manifestation of Parkinson's? Is there a causative role? We don't know. But certainly there is a link. And that explains too, you know, why patients with Parkinson's disease also have quite a bit of GI issues. Okay, so how common are the GI issues in Parkinson's disease? Sorry, this table is super tiny here, but I'm just going to try to point out here a little bit. But you can see that by the numbers, GI issues are very, very common in Parkinson's disease, in the ballpark of more than 50% of patients, okay, for the different kind of GI complaints. So we're going to talk to them a little bit more separately in detail. How am I doing on time? I'm doing okay on time, doing okay on time. Okay, and if anybody has a question, again, raise your hands. So drooling and dysphagia, okay, so that's very, very common. So drooling, you know, in some series, up to 80% of patients with Parkinson's, and you know, will develop drooling, you know, at some point in their disease process. So again, very, very common, okay? And there are several, you know, it really impacts the quality of life. So that's the thing, you know, with GI symptoms. Many times imparts function, but also your quality of life. There's that stigma and social embarrassment, you know, problems with oral hygiene as well, difficulty eating, right? Okay, and speaking. And a big, big thing is aspiration pneumonia, right? So I was sharing here at the table, my stepfather-in-law has Parkinson's disease, and he was diagnosed a few years ago after he had a stroke, you know, and he had a kind of a bumpy ride since his diagnosis, but just 3 weeks ago, he was in the hospital with aspiration pneumonia. So this is something that it's, you know, it is a big deal. And also, of course, decreased quality of life. So the funny thing is, you know, you can have drooling, but you still have dry mouth, which is particularly frustrating for patients, right? And again, you know, if you come and see us, and again, this is very multidisciplinary approach, okay? Your neurologist, you know, probably will be the first person you're gonna see in clinic, and you mentioned that you may try some medications. There's a whole bunch of medications that we can try for this particular, you know, symptom. So please make sure, you know, if you're not asked, kind of, you know, speak up and speak out, okay? You don't have to suffer. Anyway, dysphagia, someone asked over here, right, if dysphagia was associated with Parkinson's disorder or trouble swallowing. Dysphagia is trouble swallowing, and it is, right? Now, there are different kinds of dysphagia. One, the most common we see with Parkinson's is oropharyngeal, which means you have a hard time passing food from the mouth into the esophagus, okay? And you can tell that if you're a caregiver. How many of you here are caregivers? Okay, awesome, very good. So if you see your loved ones, you know, when you're eating and they're chewing, you know, and they try to swallow and they cough, right, or have a choke kind of feeling, that could be oropharyngeal dysphagia, okay? So just kind of keep an eye on that. If you see that, or if you feel that yourself, do mention that to your doctors, okay? Because what can happen is that you can have food go in the wrong pipe, it goes into the lungs, and then you end up with aspiration or pneumonia, okay? So, swallowing problems can also be esophageal, which means it's a problem with the motility of the esophagus, okay? The therapies, how we treat dysphagia, they are, you know, it depends on the nature of it. If it is a problem, what we call oropharyngeal, which is higher up, you know, a lot of the times we're going to go through a path where you have the swallow evaluation, you work with speech pathology, we do modifications on your diet. You know, this is kind of like physical therapy, occupational therapy for the, you know, for the swallowing, and try to get that to be better. If it is esophageal dysphagia, we do, there are some medications we can try to increase motility of the esophagus. Or sometimes, you know, if we cannot find, depending on how advanced it is, you know, giving supplementation through a feeding tube may be necessary. So again, the workup is pretty straightforward. It's nothing really terribly painful or invasive. I mean, most of the time you do recommend doing endoscopy, just to make sure the gut looks okay, you don't have stricture, inflammation in the esophagus, things like that. And the other tests are known, is less invasive. You know, you do like x-rays with barium and things like that. And again, the treatment is for the underlying cause. It really depends whether the problem is up higher or in the esophagus, right? And you know, there's a component that we work very closely together with the dietitians as well. You know, so it's a multidisciplinary approach. Sometimes we do need, some patients do end up with feeding tubes, and I just want to put here as a picture of the feeding tube, you know. And I mean, just like yesterday, I placed a feeding tube on a patient who needed it for, you know, a neurological disorder. And it's, you know, it's an outpatient procedure, you know, done endoscopically, you don't feel any pain, takes a few weeks for the site to heal. And once you have it, you know, you can even exchange it to have a low profile type feeding tube. You know, we place this one first and we exchange it later. So it's actually not, you know, it's not as bad as it sounds, really. Feeding tubes are pretty easy to care for, should you need supplemental calories and nutrition. Right, any questions here? Oh, we're good, okay. Another thing I wanted to talk about is about malnutrition, H. pylori, and small intestinal bacterial overgrowth. So malnutrition is fairly common in patients with Parkinson's disease. Up to 60% of patients may experience some form of malnutrition, okay? Sometimes we see folks that they have a very heavy set weight and we think, oh, you're not malnourished. That's not true, okay? Your weight and nutrition are two separate things. You can still, you know, have muscle wasting even though your weight is okay. You know, that's what we call sarcopenia. So it can be secondary to decreased oral intake for a lot of different causes. For instance, depression, you know, you have decreased appetite, you eat less. Or medications that we use, right? Sometimes your stomach is just upset when you take a bunch of medications. You don't feel like eating, okay? It can be because, you know, you have to time your Parkinson's medications in a certain timing and you feel like you don't have enough time to eat, or timing, you know, logistical issues, right? And it can also be because some medications like levodopa can increase fat metabolism, okay? And also the caloric demands of muscle. So your caloric needs just went up and you're just not keeping up with them, okay? So it's pretty common, okay? Something also to keep in mind is that levodopa interferes with metabolism of some important vitamins. So you may need to have supplementation of vitamin B6 and B12. In generally, I think it's just a good idea for everybody to take a multivitamin in general, whether or not you have Parkinson's disease. So again, the management for malnutrition is multidisciplinary. So if you have any concerns about, you know, your nutritional status, I think certainly communicating with your doctors. And what we usually do is we talk to you, you know, we kind of have some measurements, right? How is your weight doing? How your blood counts? Any signs of micronutrient deficiencies? We may do a blood test. So it's pretty simple. We do blood tests. And then if you identify areas of concern, we work with your dietitians, you know, to kind of, whether it be supplements, whether it be like, you know, targeting your dietary goals. So try to get you to be where you should be. Certainly, when you have good nutrition is when your body is going to perform best. So we really try to pay attention to that. Now, H. pylori. How many of you have heard about H. pylori? Raise your hands, of course, here. Okay, very cool, very cool. So H. pylori is kind of cool because the doctor that described H. pylori, his name I believe was Dr. Marshall, and it was like in the 90s or so. It was a big deal because up to the point people thought that ulcers were caused by stress or by spicy food, you know. And now we know that that's not true. So, you know, you can eat all the spice you want, okay? It's totally fine to eat spicy food, yeah. So H. pylori is a bacteria that most of us have. I'm originally from Brazil, so for sure I have. I haven't checked, but I'm pretty sure I have it. You know, like in certain parts of the world, the prevalence, you know, this is like 90% of people have this bacteria. So it's very, very common. And, you know, it's a bacteria that we acquire when we are little, like when we are toddlers, when you're putting everything in your mouth. And, you know, it's passed probably also in the saliva. So in many cultures, you know, moms chew the food they give to their toddlers or, you know, just for that contact in the household. So H. pylori is very common. And most of the time, it lives in the stomach, just beneath the surface. And it doesn't cause any trouble. You know, it's just with us. You know, it's kind of like a symbiotic relationship. But sometimes H. pylori comes to the surface and causes inflammation, and we don't understand exactly why that happens. Some people are predisposed to that or not. There are a lot of complex, interactions there. But H. pylori comes to the surface, and it can cause ulcers. It can cause inflammation in the stomach, what we call gastritis. And sometimes this inflammation is chronic over many, many decades and affects how well the stomach can secrete acid and how it can do its job, That's what we call atrophic gastritis. But anyway, so, but H. pylori, what the link between that and Parkinson's disease is that, patients who have Parkinson's and have H. pylori tend to have a more difficult time absorbing the medication. So that's kind of important, right? And especially, how many of you are on therapy for Parkinson's, on medication, medical therapy? So quite a few, right? Yeah, so it's really important when we give medications to our patients that we can predict how it's going to behave, right? If you give it one day, it behaves one way, you give another, it behaves a different way, you don't know exactly what to do with the dosing. And H. pylori is one of those things that it has been shown to affect the absorption of Parkinson's medication. So whether or not you have symptoms of H. pylori, and symptoms can be like just indigestion, bloating, kind of like epigastric, pain. It shouldn't be like severe pain, but it can be kind of a nagging feeling in the stomach. It might be worth checking to see if you have it. And checking is super simple. It's a stool test. Okay, so it's just we don't need just need a stool test. And if you have it, we treat it with antibiotics for 10 days. It has to be a cocktail of antibiotics, but it's pretty effective. So it might be worth having that checked. Another thing that really affects how the medications are absorbed is this thing called SIBO. It's a kind of a cool thing to say, SIBO. But it stands for small intestinal bacterial overgrowth. So all of us have bacteria in your gut, right? Mostly in the colon. And this bacteria is there for a reason. So actually, if you were to count in number of cells, we have more bacteria in your bodies than we have human cells. So we are mostly walking bacteria. Okay, all right. So keeping it alive. Okay. So anyhow, so this bacteria is mostly in the colon. There's some in the mouth too, and there's some in the small intestines. Okay. So, but there's always a balance. Your body should be in balance. So if you have too much or the wrong kind of bacteria in your small intestines, they don't belong there. Okay, and it can manifest as diarrhea, bloating, and malabsorption. So it means they are getting in the way of the job the small bowel is supposed to be doing, which is pretty darn important, which is to absorb all the nutrients that we eat. So it also absorbs the medications that we take. So again, very important that it works properly. So if you have the SIBO deal, really, you can have more fluctuation of your symptoms. Right, motor symptoms, because your medications may not be absorbed as predictably as they should. So that's also kind of important. Then, how do you diagnose this? A lot of patients come to clinic and saying that they have bloating, right, and discomfort. That's a very vague symptom, and essentially so many things can cause bloating and belly discomfort. There is a few different breath tests that we can use to diagnose this. Our institution does not have those breath tests, and they're not the best tests anyway. Many times what we do is just take a good history and give you a trial of treatment, which usually is a special antibiotic that stays in the gut, and it's been very, very, very good at kind of promoting regularity in our bacterial composition. But that's something certainly that, in the right setting, it can be beneficial. So again, this is just showing the interaction. So we have H. pylori, and we have this small intestinal bacterial overgrowth, certainly affecting how medications are absorbed. Finally, here, going to the nitty-gritty details. So constipation and gastroparesis, they're all very common as well. So gastroparesis just means delayed emptying of the stomach, okay? And again, when I mentioned the stomach does a pretty hard job. It seems simple, but it's not. You're grinding the food. You have to only allow food at a certain rate to go in the small bowel. You're a reservoir for food. And of course, our stomachs and our brains are linked, right? You guys remember when, we were little and, maybe in kindergarten, and you had to do something that was challenging, right? Maybe you had to speak in front of the group, maybe you wanted to ask a girl out or a boy out, and, you got really nervous. Where do you feel it? You feel it in your stomach, right? You don't feel it in your heart. You don't feel it, you feel it in your gut. So again, our stomachs are mirrors to what's going on, everywhere else in the body. And gastroparesis, again, very complex. And gastroparesis, it means, that the stomach's just not emptying very well. And it can be due to a medical problem, okay? And again, the gut's kind of like a mirror of the body. For instance, patients with diabetes often have this, right? Many patients with neurological disorders also have gastroparesis, and it can also be due to all the medications that we take. Medications really affect the gut. And levodopa particularly can cause gastroparesis. It's just one of those things. It is what it is, So we only have a few medications available to treat gastroparesis, and Reglan typically is contraindicated in patients with Parkinson's because of interactions, right, with levodopa. So, but if you do have this, there are some other alternative treatments we can give. Some medications that we give, they kind of like just make the gut feel better, which is very important. It's just like, that way you feel like eating, improve appetite. Other treatments we do can be more mechanical. We do endoscopy, we inject Botox in the stomach, things like that. Okay? But again, if you suspect you have gastroparesis, please see a GI doctor. And again, constipation is the most common GI symptom in Parkinson's disease patients. And I would have to say it's probably one of the most common reasons why folks go see a gastroenterologist in general. Okay, it's funny, not funny, but I think I just find it very rewarding in my field that I see patients many times in the hospital who they have, oh my gosh, they had such a tough time in the hospital, right? They might have had like a motor vehicle accident and surgeries, and they are, have all these drains and tubes on them, and you ask them what bothers you the most, they say, I'm constipated. Because constipation can be miserable. There's, if you were to define what constipation is, probably it will be different for like all of us. Some people say, oh, I haven't had 2 bowel movements today, I'm constipated, because they're used to having more. Some people can go 3-4 days without a bowel movement, and that's pretty normal for them. So essentially, I tell my patients, you're the best person to tell me if you feel constipated, because you know it. It's just one of those things, hard to define, but easy to identify. If you have it, you know it, okay? So we do have some criteria that we use for it, but essentially, a lot of this is patient-driven. So when you go see a doctor for workup or constipation, we do a whole lot of things, usually. First is a good history about what is normal for you. So, and again, that varies a lot from person to person. And then we try to figure out what is causing the constipation. Sometimes it could be as simple as a mechanical kind of issue, like I'm not moving as much as I used to anymore, or maybe sometimes it's diet, my diet has changed. Many times it could be side effect from drugs, so we have to look at the whole picture, okay? And then depending on our workup, you also check for, let's say, thyroid hormone levels and other things. So we do some blood work as well. We try to find the cause of the constipation, and then depending on that, we, come up with a care plan, okay? And the care plan usually involves more than just giving medications. If you have to address dietary issues, we do that too. And if you need to do further testing, such as colonoscopy, just to make sure the colon is okay, there's no obstruction, we do that too. Okay? So there are many causes for constipation, but most of the time it is really a combination of things. It's not just one thing, and that's why we use different strategies to treat it. Okay? And again, a lot of medications cause constipation, including levodopa. Pain medicines cause constipation, blood pressure medicines, iron supplements, so a lot of stuff. And many times patients they don't talk about constipation to their doctor because they're afraid that they might need a colonoscopy, right? I mean, who wants to get a colonoscopy? I mean, right? I mean, Honestly, it's not that bad, but gosh, it's that darn bowel prep, that gets to people. And I mean, I hear it. I've had it myself, so it's not fun. So, you don't necessarily need a colonoscopy, okay, if you have constipation. So talk to your doctor. If you experience that problem, go ahead and open up. But usually colonoscopy are for those who have had significant weight loss, or if you have bleeding in the colon, or if you have significant anemia that we cannot explain, or if you had a family history of colon cancer, usually. Those are good reasons to look with the scope, okay? I'm going to just skip this a little bit. There are different kinds of constipation. Some people have normal transit in the colon, they're constipated, or they're a little bit sluggish, but in the end, oh, and finally, this is important, also some folks may have problems expelling the stool from the rectum, okay? And again, Dr. Wakefield here might empathize with that because the bladder and the colon, the rectum, they're next to each other and they kind of, interfere with each other. So this is something you might see. Patients who have bladder problems too, just because of the structure and anatomy of your pelvis. So if you have problems pushing out the stool, okay? Everybody's had breakfast, nobody's eating, right? Okay. So if you ever have to manually disimpact yourself, it's okay. Tell your doctor, okay? If you feel like you need to bring your knee up to kind of expel a stool, it's okay. Tell your doctor. Because those are signs that you might be having a problem with the outlet, right? And that usually require special evaluation and management, okay? We can do like pelvic floor rehab, okay, exercise to kind of help you get the stool out. Because if you're just kind of holding on the stool all the time, it doesn't matter if your colon is working. If you cannot get out, we need to target that, okay? And again, important to discuss. And for medications, there's a whole lot of medications that can be used. We use laxatives, stimulant medications, stool softeners. There are some also fancier agents now on the market. You might see commercials for Linzess and things like that. A lot of good choices, essentially. So we should get your bowels moving. No reason not to. Okay. Okay. So in summary, just talking about all the different gastrointestinal symptoms we talked about, and they are very, very common. So the key message is, if you suffer from a gut issue, please talk to your doctor. Let us help. Okay. Alrighty. One final thought. So everybody, have you guys heard about the microbiome? Anybody? Everybody, the doctors here. Okay. So this is a huge topic in GI. It's like you go to a national meeting and have like 10 different talks on it, and it's so complicated. And essentially nobody knows anything concrete. So that's what's so confusing about it. But essentially, as I mentioned, we all have all these billions of bacteria in our colon, and they're there with us for a reason, okay? They help us break down some vitamins and digest foods. They are very metabolically active. So we have a petri dish in your colons, essentially, okay? That's okay, because they're there helping us, okay? They're supposed to be there. But sometimes you have an imbalance of the composition of that bacteria. And sometimes that happens because we're taking antibiotics, and that kind of, wiped out the system. Sometimes that happens because our diets have changed, or because we have problems with motility in the gut, and it's a jungle out there, right? So if you have a change in ecology, you have a change in composition of those bacteria, and you might cause some issues, right? So this is just talking a little bit about the intestinal microbiome a little bit. And one thing that I like to tell my patients and my trainees is that if you have the habit of weighing yourself in the morning, like I do that, right? I wake up every morning, I use the bathroom, get on the scale. It's just something I do. And you see that number, and just realize that that weight is minus five pounds. Okay, so you are automatically 5 pounds leaner than you think you are, because that 5 pounds, it's stool, and a lot of that is just bacterial mass. Okay, so there you go. You feel a little bit better. So so you're all 5 pounds less here. Okay, so there are different composition of bacteria in there. I'm not going to go into details. Okay, but why the gut's so important there? Because whatever we eat, it's kind of a foreign thing to your body, right? Like if you eat an apple, it's not part of your body. So how does your body know that it should not fight the apple, right? Or if you consume bacteria by mistake and you get sick, like let's say you have some bad E. coli in some lettuce somewhere, you would expect your body to kind of try to fight it off, right? So the body kind of has to decide what to accept and what to fight. And a lot of those complex interactions happen in the gut. Your gut has so much lymphoid tissue. It has all those, like, the frontline soldiers that you see, if you think about, your body being a war field. I mean, like the soldiers, the ground troops, they're in the gut. Okay? They're there doing the work, recognizing what they should fight and what they should ignore, who is a friend and who is a foe. So it's a very, very complex immune interaction. A lot of immune diseases have been kind of associated with this dysbiosis or irregularity in the gut. And what we know about, so that's the dysbiosis, and we know that some diseases are linked to the dysbiosis. Did the dysbiosis cause this irregularity in the gut, the flora? Did it cause the disease, or is it a side effect of the disease? And probably both. They're probably linked. Now, many diseases have been associated clearly with dysbiosis, okay? But also, I just want to link Parkinson's disease, also autism. There's a research on autism and also dementia. So essentially, what we know, and this is a super tiny slide and kind of complicated, but what we know, essentially, if you look, patients with Parkinson's disease have very different bacterial compositions in the gut as compared with patients with other neurological disorders and healthy controls. So that's some interesting fact, just to kind of, there might be something unique about Parkinson's disease in the gut, okay? But keeps the slide. So, we are, and our gut flora is essentially just on a very basic level, when Hippocrates, said, let thy medicine be thy food and thy food be your medicine. I truly believe that is close to heart because, so this bacteria in our guts, we will grow whatever we feed, okay? Whatever we feed is what will grow. So if you want a good gut composition, let's pay attention to your diet. So that's another point here in the message of this talk is, high sugar and high fat diets are bad. And when I say high fat, I'm not talking about like natural fat. I'm talking about saturated fat, the kind that cause heart attacks and stroke. So that's really bad for your microbiome, okay? And usually complex carbs and veggies are good. Fiber is good in general, okay? And refined sugars are not so good. So if you haven't eaten that muffin in our boxes, don't. Okay. And by the way, I had no input on what it's in your breakfast box. Okay, that's a little disclaimer. Okay, no idea. Okay, and high meat protein, too much animal protein is also not so good. Okay, it puts kind of a stress in the gut, in a sense. Okay, it has a lot of bad fat. Typically, that's not good for you. So finally, so we change our diets. Can we use probiotics? So yes. And there has been some studies that show that patients who take probiotics have less depression and anxiety than patients that don't. Okay, so, again, it's an association, it's not causation, and honestly, we may never know the exact mechanism of that, but it might be worth considering having some probiotics, okay? The problem is that there are so many different formulations. If you go to even like a normal grocery store, like Walmart, you're probably going to see 10 different brands, and different price points, different compositions. So you're like, what should I buy? Again, eat a healthy diet is usually, number one. And second one, if you're going to have a probiotic, I have a rule of 4, okay? Just make sure it's more than 4 billion CFUs, and that's the strength of the probiotic. You want something that will survive the acid in the gut, okay? Because if your probiotic does not have enough colonies in it, the acid in the gut might kill the bacteria, so nothing will reach the colon where it's supposed to. So make sure it's more than 4 billion CFUs, that's strength. More than 4 different strains because you want a variety of composition. okay, in your probiotics. Usually it's a combination of lactobacillus and bifidobacterium, which is good, okay? And then you want it to be a capsule, not a chewable, okay? A gummy probiotics really don't work. I mean, you know, they dissolve in the stomach and the bacteria is killed and you wasted your money and time and effort. And stick with it for at least 2 months. I have a lot of patients who start on probiotics for various reasons and say, Doc, I didn't see any difference, so I stopped. I'm like, okay, how long have you taken it for? Oh, I took it for a week. I'm like, you know, nothing's going to change in 1 week. You know, you cannot change ecology in a short amount of time. It takes weeks and weeks and weeks, you know, for that to kick in. So stick with it for at least 8 weeks, okay? And I think that's what I had for you guys this morning. And oh my gosh, I am right on time.